When clients enter a clinical setting, they often arrive carrying deeply internalized diagnoses. They describe their struggles not as things happening to them, but as evidence that they are inherently defective. In this standard model, a diagnosis becomes an identity. A person doesn't experience depression or anxiety. They are depressed or anxious, overwhelmed by a static, inescapable cloud of despair. Looking at this analysis of narrative therapy, we see a specific structural alternative to this internalized model. It is a technique called mapping the influence. Developed by Michael White, this technique pivots the therapeutic approach around a process called relative influence questioning. Instead of trying to fix a broken mind, the therapist investigates two distinct directions: how the problem affects the person and how the person affects the problem. As highlighted in the objective here, the goal is to transition the problem from an internal defect into an external force, one that has a measurable, but not total, impact on a client's life. This process functions as a diagnostic tool that explicitly avoids pathologizing the client. It diagnoses the relationship, not the individual. By charting the space between a client and a problem, the therapy shifts the focus from an immutable trait to a relationship that can be observed and navigated. The process begins with Phase A, examining the problem's influence on the person. The clinician's goal here is to ask precise questions that trace the problem's destructive path through the client's day-to-day experience. They map out specific domains: how the struggle dictates work performance, how it distorts self-image, and how it infiltrates personal relationships. Consider this diagram visualizing guilt. The clinician maps how this central node branches outward, claiming territories like relationships, work, and self-image. The therapist asks, how does the guilt convince you to isolate? This framing separates the person's intent from the problem's demands. This exhaustive questioning continues across all domains of the client's life, documenting the specific, rigid boundaries of the problem's current territory. Phase A requires the therapist to fully witness and document the extent of the damage, establishing a baseline before any forward progress can be measured. Once that baseline is set, the inquiry pivots to Phase B, the person's influence on the problem. This is the countermapping phase. The objective is to uncover historical instances of client resistance and actions that align with their own values. Returning to our network, we look for moments where distinct actions push back from the relationship's node, actively halting the expansion of guilt. The clinician asks, in what moments recently were you able to step out and see your friends despite the guilt's protests? This specific phrasing acknowledges that the problem is still vocal while reinforcing the client's ability to act in spite of it. As noted in the clinical evaluation, this creates a structural effect, acting as a psychological scaffolding for the client. By establishing this boundary, the once vague cloud is transformed into a specific adversary with limited, defined territory. The primary diagnostic strength of this approach is finding true empowerment through an objective, visual awareness of one's own ongoing control. As therapy progresses, clients can tangibly describe the shrinking of the central node, visualizing the expansion of the life territories now under their control. The resulting map provides a structural representation, showing that the problem does not and cannot occupy the entirety of the client's life. However, this document also highlights that externalizing a diagnosis requires careful clinical trade-offs. The first major risk practitioners must navigate is intellectual exhaustion. Maintaining a sustained structural metaphor demands significant cognitive bandwidth. For a client experiencing physiological brain fog, this creates a high-friction cognitive load. Clients who are severely impaired by acute depression or medication regimens may struggle to process the complex dual mapping required to make this work. The second limitation outlined is known as the dualism critique. This is the danger of drawing a stark line separating a pristine client from external dark negativity. If applied too rigidly, this strict boundary obscures hidden cyclical feedback loops, making it difficult for clients to reflect on their own habit formation. While externalization is a highly effective conceptual tool, clinging to it as literal truth can actively block critical self-reflection. Finally, therapists must carefully manage therapeutic pacing to address a client's core validation needs. There is a distinct danger in rushing past the mapping of Phase A and jumping straight into Phase B. As the top of this page warns, Moving too fast can cause the client to feel their suffering is being minimized before it is fully witnessed. Looking at the final conclusion, we evaluate the role this technique plays in long-term treatment. Mapping the influence functions as an essential first response in narrative therapy. It breaks the totalizing power of an internalized diagnosis by giving it a shape, name, and specific limits. Defining these borders isn't the end, but as the report states, it is indispensable for reclaiming agency and initiating the reauthoring process. When clinicians balance these structural mechanics with patient pacing, they lay the foundation needed to begin reauthoring a life.